Good morning. Thank you everybody for showing up. Today's talk is a very simple revision of whatever diabetic retinopathy is all about. First of all, let me tell you something about myself. I've started this thing with a master and PhD thesis in, where is it? That's fine. Okay, thank you. So I've started my career with a master and PhD thesis in diabetic retinopathy. I've been doing this for the past 18 years, and I have no financial ties to disclose. Okay, so the core of the thing is we are here today because we have an epidemic. It's projected by the 2040 we'll have about 1 in 10 adults that have diabetes. With more diabetic people, we have more diabetic retinopathy, and then we have more complications and blindness and things to deal about. Vision loss is predicted to be 30% of those who have diabetic retinopathy, and a third of those will have some kind of impaired vision. It affects working adults, it affects all social fabrics of life, and that has a lot of impact. If you want to know, just patch one eye for a couple of days or both eyes for a couple of hours. You will understand. That's why we are fighting this like the disease it is. Problem is, it affects the psychological and physiological well-being, and it robs you of your independence. Each adult that cannot see needs at least a family to take care of his business. And we have patients who have actually wanted to trade their blindness for something other disability, like losing a limb. I wish we could choose, but we can't. So the problem is, why is it so difficult to tackle this? It's the nature of the beast itself. It's a chronic vasculopathy, it takes hold, and it comes in various colors and flavors. So it runs a slow grinding course. Some people are really disabilitated very quickly, and sometimes they barely feel it. Then we have different requirements of vision. Some people are, very fussy, type A personalities, and we have all the Hakuna Matatas who just don't care. And then we have various experiences. If you have heard that a friend or a family member has lost vision, it's totally different if you have heard that a stranger had the same thing. And then we are having to deal with the psychology of the patient. In which stage do we see the patients? Unfortunately, I see a lot of them in the first or second thing when they're first manifestation. I tell them that they are diabetic because they have lost vision. And this delays treatment because of depression, sometimes for years on end, and we don't see them again. And one more thing, that diabetic retinopathy affects centrality. It's a posterior segment disease, but it doesn't have to be very central. That doesn't mean that it affects vision right away. In the photo there, you can see that the yellow circle denotes the central vision. This is where the most vision is. So in this case, even in vitreous hemorrhage and even traction and retinal detachment, the end stage of diabetic retinopathy, patient still sees well. He drives, they drive, they watch TV, they do about their daily activities unhindered. This disease drags retina surgeons to the course more other than often. You can see that the center is attached, so the patient sees 6/6. And it's a moral issue actually. Would you take the patient to surgery and lose vision, or you stay quiet and still you lose vision? Then this is a patient who has a multisystemic disorder. He has a lot to deal about. So they tend to prioritize. Vision, it's okay, I'll check my eye later, it doesn't matter now. And they have a problem. Each and every visitor, doctor costs money and drops patients of his money in exchange for his health. Or presumably, we are doing a good job. Then we have some awareness obstacles. We have run a lot of free screening programs in which patient doesn't pay anything. We are just screening the common public in malls. And they come up with things that you're inventing diseases, or I'm special, I'm different. They're blind for another reason. And then if I get a problem, I have a superpower to take care of it. Whether I'm insured, I'm extra rich, I have friend support, or God will take care of it. And then there is a human tendency to procrastinate. It can be done tomorrow. Common, medicine is improving, and hopefully we'll get a cure soon. Let me walk you through diabetic retinopathy classification. It's important just to know what each and every term means. This is back of the eye. This is a normal, healthy fundus in which you have the yellow circle always denoting the center. A microaneurysm is simply small dilatation due to weakness in the pericytes around the wall. It's very small, it's a small bulge, it looks like red dots. It's very hard to see in this. Those are a couple of there, and I've enlarged it for your viewing. They are very small, obviously, and they just tell us that the patient is diabetic, nothing else. Then we have hard exudate. They are called hard for a reason because you can draw them, you can just encircle them. They are just deposits of lipoproteins, and they denote a larger leak from the vessels. They are space occupying and toxic. We don't like them, especially if they are near to the back of the eye. They can be in focus, a small circle, or they can be so extensive as in the lower photo. Then you have macular edema. Hard exudate or yellow stuff is not macular edema, it's fluid that's collecting inside the macula. And it can be clinically significant, that means it's vision threatening, it needs immediate treatment, or non-clinically significant, that means it needs to be seen after some time. In those non-significant cases, they resolve on their own once your A1C starts improving and so on. Here is a cross section. This is an imaging modality called optical coherence tomography. On the you can see the normal one there, and you can see some fluid spaces collecting in the macula. Vision gets affected on those people. Then we have vasculopathy. Diabetes is a chronic vasculopathy, and you have three flavors: mild, moderate, and severe. And then you have the proliferative variety. We'll talk about each in a minute. A mild, you get to just one microaneurysm, and it just means that there is some disease. Nothing should be done, and you can see those. This is a fluorescein angiography in the lower slide, and we'll call it fundus fluorescein angiography. We use those just to detect the small macular aneurysms and anomalies. Then you got the moderate variety, in which you get capillary bed abnormalities, you got venous beading, and then you get a lot of dot and plot hemorrhages. They are all the same. It depends upon where they are situated, how deep they are. They can be a dot or a plot. And then you get the cotton wool spot. As you can see, they are fluffy in shape. They just denote that the systemic control is not up to mark, and they go on their own. Then you get the severe variety, in which you get hemorrhages in all four quadrants. That means all four sides of the eye from the inside. You get venous beading in two, and you get the dreadful IRMA. IRMA is vessels that are aimlessly running across the retina. They don't do anything, but they don't leak. Here is a normal capillary bed for the comparison if you'd like to compare photos together. So this rule is important. It's called 4-2-1 rule, because 50 to 75% of those people who have severe non-proliferative diabetic retinopathy with 4-2-1 rule, they convert to PDR. They are high risk and they need continuous monitoring. Then we come to dreadful PDR. What happens actually is severe non-perfusion. Blood is not reaching where it should. Cells scream for help. They secrete a vascular endothelial growth factor, and this tells the vessels to take things into their own hands. They start shooting new vessels. They are inexperienced and fragile, and they don't just supply anything, but they lead to other complications, and those need treatment. Now the eye is a very vast space. As you can see, the macula is still the same size, red circle in the middle, and you can see there is a lot of retina inside. New vascularization elsewhere, those are the, as you can see, start to become proliferative. They proliferate, fan-like. They don't supply oxygen. They are prone to bleeding. And then you get the dreadful vitreous hemorrhage. It can be covering half of the eye. Can be very small and far away from vision that the patient never notices them, and it can be so severely disabilitated like this. Problem is, I see so many patients with this, in which one morning they wake up and their whole life streams to a dead end. Okay, so the optic nerve is also a part of the eye. Yes, it runs to the brain, but we deal with it. So new vascularization in the disc means there is severe ischemia in the whole of the eye, to the degree that even peripheral vessels cannot make any new vessels. It can be very small. It can be also lead to vitreous hemorrhage, as in this case. Now, optic nerve does also get inflamed. It can be so severe like this. It can be um, uh, limited, and it can be normal looking congested disc. It doesn't look like optic neuritis at this time, but it is, as you can see. And then you get the end stage. Here where my job stops. I cannot do anything for the patient because the nerve is not functioning anymore. It can be waxy, yellow color, and here is a normal nerve for your comparison. Now, we do see, unfortunately, I see a lot of these patients, the doctor shop, and they have a perfect excuse, they don't see anything. It can be due to ischemia, there's no blood running around, and it can be also due to scarring. Those are the horror stories that we are trying to avoid by coming here. Now, how do we manage those? The whole thing starts with early detection. The sooner you get them off the line, the better they fare. So problem is we are not doing a good job. At least I'm not. And we are getting less than 30% of those who are predisposed to diabetic retinopathy. Vision is always affected in these cases, and it's an uphill battle that I usually lose. It's expensive and it's lengthy. Here, communication actually plays a very important role between patients and all his treating doctors. It's not just one. I'm just a member of a team that manages the patient. Then we have got the gold standard. This is what we hear as we told the patient to do laser. It's just because it is gold standard. It has been there for at least 200 years and it has a proven track record. But it requires training, skills. It is destructive in nature and has a lot of limitations, but still functions. This is what one of the new innovations is called a scanning pattern. If you have not seen a laser procedure before, this is one in which multiple shots of laser are being fired at the same time, up to 56 months. And this is what a band retinal photocoagulation looks like. You can shoot one by one or multiple at a time. This is what I see. It's a vast space inside. Okay. Then we have got the new armamentarium of injectables. As we remember, in proliferative variety, we had vascular endothelial growth factor, VEGF, and we started our journey in 2002 with inflammation in general. So triamcinolone was doing a great job. Then we discovered that there's a specific factor that needs to be addressed. And in 2006, Avastin came along and is still doing strong. In 2010, a more potent drug came along, Eylea, and it's projected by the end of this year we'll have about 10 more. So the pipeline is really busy. Then we've got the low follow-up. The problem is patients get a sense of false closure. They have done their part. They have done laser. They have done whatever. We lose them to follow up. And we have all the previous obstacles, you know, decentrality and doctors inventing medicines and diseases for us. Okay, so what's new? On the treatment front, we have the detection updates. We've got better reading abilities. So whenever we screen on a national stage, we are getting better at predicting who has the disease, who needs more follow-up, and who's not. Then we're getting also at cameras. Putting drops to the eye is a real nuisance. I hate it, my patients hate it. So we try to do with it with the better cameras. Then we try to integrate this with other health services. If you show up for your other factors, probably a screening camera there would help. And then we are establishing a national database. Bahrain is doing a great job. One more thing is a small accessory for a phone that makes even fundus photography even to the common public. If you know what you're looking for, you can just snap a photo and send it to a doctor somewhere. Then we have longer term injections. We started with a triamcinolone that lasts for 15 days, Eylea lasts up to 2 months, and now we're getting up to 6 months. Then we've got the auto pattern laser. This is robbing me of my job, but I'm showing it to you. This is in the front line, a retina specialist is snapping a photo of a patient's eye. As you can see, he has diabetic retinopathy. What he does is actually tells the machine where the optic nerve is, where the macula is, where not to shoot laser. Then he's designing the laser treatment as if he's doing it on his own. Once he's done with this, he just put the machine on autopilot and he just observes. Now this would allow more people to get treated with laser. So what the machine does, it just tracks the eye movements. If a patient blinks, it stops. If he moves or she moves her eye, it just stops and rechanges. And then you've got end of tree. So it's facilitating this to more people. Then we've got better at referral. We are getting better at communications. It's if this can be applied to a national level in which you show up for your driving license and they need your retina screening because you had a diabetes, that will help a lot. Not just because we gain money for it, even free services are offered. But still we're getting patients slipping through the cracks. And the more we have a seamless process between doctors and patients, the more we are good at this. Then we have got something like deep learning. Deep learning means telling a machine, teaching a machine to do something. You feed it data and it comes up with the results. So this is the process where how the machine thinks. It's yes, no, perhaps, or doesn't apply. And this is what the machine sees. What this is back of the eye. What looks like normal to us, this is what the machine sees down there. So the machine doesn't think, but it extracts data from a normal streaming book. Imagine you have to screen a country like India or China. You need an army of ophthalmologists to take a look. So it reduces the burden on us and it removes inconsistencies between us. Obviously, anything done by a computer would be cheaper. That's it from me today. Thank you very much for showing up. You've been a wonderful audience.
Thank you, Dr. Samad, for this really interesting images and installation. Any questions? We have time. Yes, please.
Thank you very much for the interesting lecture. I wonder if there is any role of visual evoked response to predicting or detecting cases that you follow.
Well, so there is a role, but it's still a research. The whole problem starts with ischemia. That means there is not enough oxygen. That means some cellular function is impaired. But the problem is with visual evoked potential, it tells us what the whole eye is doing. Probably is doing fine. So it doesn't have a lot of role in a clinical or a treatment at this stage. It doesn't, but in a research-wise, yes, it's doing.
Does it show how much demyelination of the optic nerve?
So demyelination is important, but it's not part of the diabetic retinopathy. We are talking about lack of oxygen supply due to vasculopathy to the whole retina. So it does show, but it's not a specific thing to the diabetic retinopathy. It doesn't tell us who needs treatment from who doesn't. That's why it's not applied clinically at the moment.
Great lecture. It's a question, what is the percentage for improving? In other way, why some patients compliance issue, or what is the percentage of the improvement that when you do the laser or the injection?
To be honest, what I do is try to stop a disease on its tracks. The sooner the patient realizes that his general condition dictates the success, the better I am. So if a patient thinks that what doing laser, taking injections or paying me extra is getting a better vision, that doesn't happen. He has to be involved in the treatment process. So it varies from one person to another. That's why the Kubler-Ross model is very important, because I have sometimes to refer them to psychiatrists. They lose their driving license, they lose their independence. Sometimes they complain they cannot see food or see friends, family, colors and everything. So the psychological impact is much more prevalent in my case. The success rate, if a patient is compliant, is actually high. So we encourage people, to come early, to get treated, and to maintain a good lifestyle in which, those treatment effects last longer. So I don't have a specific percentage, but those who get treated, I was telling Dr. Sumaya, I've got a patient who had three surgeries complicated in one eye, and they end up with 6/9 vision. That's 20/40 vision. That's excellent vision, but it doesn't happen that often, I'm afraid.
Any more questions? Yes, Dr. Bazan.
Thank you very much. Very, very interesting.
Thank you.
I have a special interest. My wife is type 1 and she developed retinopathy. And she had a laser for the peripheral and she lost her night vision. And that seemed to be the usual. Now, antivascular interference factors. Now, it seems to be different from one center to another. They have routine. You suggested for every 2 weeks, and some of them they suggested every month you have to get the injection. It's very expensive. They're talking about each injection 250 dinar, and maybe more it costs. Which is really expensive for an average family. Now, do you think first it is effective? That's one thing, and probably from the research you can see. And how often you would give it, and what do you advise the patient to do? Tell the patient.
Yes. So whenever we come to the cost, we talk about cost effectiveness ratio. With how much money I pay, do I get that in return? They are very cost effective because the alternative is losing vision. And the problem is that is unrecoverable. You have a window in which you give the injections, sometimes every month, sometimes every 3 months. It really differs from one patient to another. But unfortunately, that's why we have longer acting, but they're still more expensive. It costs money to produce these medicines. To be honest, whatever we are getting as ophthalmologists or retina specialists, it's just the cost of giving the injection itself. So patient has to take the whole burden. Actually, I'm sorry for that, but it's part of you having a disease and treating it. One more thing is that if you go for laser is longer affecting, but if you have central disease, then laser doesn't work because it's just you burn the retina, burn the macula, you lose vision immediately. So injectables have a role, and probably with better agents, either we're getting lower cost or better performance and efficacy. Hopefully your wife does better.